In today's episode, we are going over weight bearing after meniscus repair. Let's get going. So, if you've been working as a physical therapist for long enough, you've probably seen this. So, you get a patient in the door, let's say Monday, 7 o'clock a.m., meniscal repair. You're like, all right, cool. I like these patients. They're fun to deal with. Patient one comes with a protocol, script from the doctor, says toe touch weight bearing for 4 weeks, and then partial weight bearing for 2 weeks. Keep that sucker locked in extension with a brace. Then weight bearing is tolerated at week 6, locked in extension. And then weight bearing is tolerated with no brace at week 8. All right, good stuff. And then patient comes in, has a good session, leaves. 8 o'clock rolls around. You get another patient. And lo and behold, it's going to be another meniscus repair. And this time, it's from a different surgeon. And you get a script and a protocol. They're also very early in the post-op phase. And there's no restrictions whatsoever on this patient, right? So I'm sure you've seen this before. You work with enough meniscus patients. Some have a super restrictive protocol and some have absolutely no protocol whatsoever. And it doesn't make sense, right? Is it going to be harmful if we weight bear too soon for some of these folks? Are we going to re-tear the meniscus? Is it okay to weight bear on the meniscus? Does it depend on the person? There's a lot of problems with this. So what we want to talk about today is, to the best of our knowledge, and we'll look at a little bit of evidence today, what's accurate? Should we be weight bearing very quickly after surgery? Should we be waiting 4 weeks, 6 weeks, right? We need to have that brace locked up, right? And should it vary a little bit based on that person, the presentation, type of meniscus tear, et cetera, all right? So in summary today, we'll talk a bit about what are weight-bearing progressions based on what the literature is suggesting. And then we're going to go over some practical recommendations, right? So essentially, based on the type of tear, the person, et cetera, what are some guidelines as a physical therapist for our patients that come in with a meniscal repair, right? So before we get going, I do have a free cheat sheet about the meniscus to kind of catch you up if you're a little bit lacking behind in terms of the meniscus. And we go over prevalence, the anatomy of the meniscus. We go over a mechanism of injury for meniscus tears. We go over a clinical presentation. What does it look like when a patient walks through the door that has meniscus pathology? We go over evaluation and diagnosis, some treatment strategies, and then also surgical considerations. I'm going to put this in a link in the show notes, right? If you're watching this on Instagram Live, you can just go into my profile and it's underneath the knee. Go ahead and download this. Apologize with folks on YouTube. There's only one right now, so they're not going to be upset, I don't think. They can't get this immediately. Most folks kind of watch this recorded version. So I'll leave it in the show notes. Definitely pick it up. Okay. It's 100% free. All right. I want to say sorry in advance because this is a little bit of a bait and switch. And essentially, I'm just going to read this from a more recent article. I'll leave all the references and show notes as well on the meniscus, but largely there's a lack of consensus regarding the optimal post-operative protocol following meniscal repair. At present, there is a paucity of evidence to support one best practice. There's a high degree of variability among post-operative rehab programs. Sorry. Additional studies are needed to better clarify the interplay between tear type, repair method, and optimal rehab protocol. So I think one of the major reasons why I see so much variance between surgeons is because no one really knows, and we're just kind of guessing, okay? And unfortunately, I think this is where we're at. When I was reading through a lot of this research to try to figure it out myself, it's almost like we gave up on this, right? We had some research coming out of the 90s and 2000s, and then 2000 to 2015 or so. And we had a little bit of knowledge that goes with that. And we're starting to figure things out. And then we just kind of stopped trying to figure out what the best protocols were. So I'm going to give you my takeaways from what I read today. But do keep in mind that it's still a bit of a mystery, right? Okay. So what are your physical therapy goals? Someone comes through the door and you're the physical therapist. They just had a meniscus repair. What are your goals? Why would we potentially delay things or go a little bit faster? So generally, programs that delay weight bearing or range of motion are initially focused on protecting the repair while regaining that range of motion, gradually introducing progressive strengthening en route to return to pre-injury activity level. So the reason for a large degree of variance in protocols is based upon an attempt to protect the repair. Okay. And we'll talk about this a little bit later, but yes, we want to protect the repair site for sure, but we're not really sure if delaying weight bearing is doing more help or actually more harm, because if you wait a long period of time to start loading someone up after meniscal repair, they get a lot weaker. They get a lot of atrophy, and then they have problems later on for this reason. So, all right, make this a little bit bigger so both you and I can see this. So the first study that we're going to look at to help answer this question is from Ganley et al. In 2000, right? So it's 23 years ago at this point. And this was the impact of loading on deformation about posterior medial meniscal tears, right? So looking at knee flexion and loading on its impact on meniscal healing. And this is a cadaveric model, so it's not going to be in live, folks. So, take all this with a grain of salt. And basically, they produced a full thickness posterior medial meniscal tear in cadaveric knees, right? So they took a cadaver and they opened up the knee, and then they end up tearing the posterior area to cut it, right? And they embed metal markers into the tear following the repair to see if we're actually separating apart the meniscus when we weight bear, right? When we load that knee. They use CT scans, and the marker position was assessed at 30 degrees, 60 degrees, and 90 degrees of knee flexion after loading of 100 pounds to simulate partial weight bearing. So essentially, they flex the knee a little bit and they load it with 100 pounds. They flex it a little bit more and they load it with 100 pounds. And they flex a little more and they load it with 100 pounds. And what they found is that neither flexion angle, loading, nor suture had a significant impact on the tear, right? So at least in this study from 2000, partial weight bearing on a meniscal repair doesn't seem to impact the repair site at all, okay? So interesting. Next study we're going to look at is from Lin et al. In 2013. And they were looking at range of motion over 90 degrees, right? So essentially in the last study, they only went up to 90 degrees. What happens when we go past 90 degrees? Simply put, a lot of protocols restrict your range of motion to 90 for a period of time. And then they give you the ability to start loading more into greater degrees of knee flexion over the course of time, maybe at week 6 or something along those lines, right? This is also a cadaveric model. And they created a 2.5 centimeter posterior medial meniscal tear and repaired it. So similar type of tear as in the last study, right? And I think it's worth noting here. But if you have a posterior medial tear, when you go into knee flexion, so as you start to bend, think about when you initiate a squat, there's a little bit of knee bending. And then at the very bottom of the squat, there's a lot of knee bending, right? The deeper you go into a squat, the more stress goes onto the posterior portion of the meniscus, particularly the posterior medial. So if you go end range knee flexion range of motion, you're putting a lot of stress on the posterior medial aspect, okay? And that's probably one of the reasons why a lot of surgeons will restrict range of motion to 90 for a lot of these tears that are posterior medial in nature, because they don't want to overstress the area, right? Sorry for the aside, but that's probably why you're seeing that. And in this study, they measured the displacement at high degrees of knee flexion. So basically, they looked at 90 degrees knee flexion with load, 110, and then 135 degrees with load, right? And they put a load of 29 newtons applied to the hamstrings and 150 newtons applied to the quadriceps. And what they showed as well is that neither the meniscal tear nor the meniscal repair demonstrated significant gapping. So if you were weight bearing on this meniscal repair, it didn't seem to gap those sutures at all. It wasn't pulling apart, wasn't making that tear size larger, okay? And rather, they compressed in the transverse plane when flexed from 90 to 135 degrees when subjected to physiologic loads. Now, this is a little confusing, and we'll talk about why this is a little bit later, but essentially, as opposed to pulling the meniscal repair apart, it compressed it together, okay? Which is probably a good thing because we want to load up the knee after surgery. And at least, from these cadaveric studies, it seems like when we load up that knee, it's not pulling the tear apart. It might actually be compressing it together, right? Next, we have a study from Richards et al. In 2005, and they were looking at pigs with meniscus repairs, right? So no longer with cadavers, they're looking at pigs at this point. So not humans either, right? So again, take this with a grain of salt. This study was called Compressive Loads in Longitudinal Lateral Meniscus Tears, a biomechanical study in porcine knees, that's going to be in piggies, all right? And they're looking at weight bearing in varying degrees of knee flexion. And what they found, just like the cadaveric studies found, is that weight bearing helped to stabilize repair. So when you're weight bearing, it wasn't pulling that repair apart, okay? So the reason why we restrict range of motion early on, like I said, is because we're trying to protect the surgical site. And in these studies, it looks like when you were weight bearing on that area, it actually stabilized repair. It didn't do the opposite. It didn't spread that apart, okay? Pretty interesting, okay? So why might this be happening, okay? How come when you weight bear on a knee that has a meniscus repair, why does that stabilize the repair? So it has something to do with hoop stress. Okay. So if you think about someone who's weight bearing, so imagine this is my tibia, right? So this is my shin right here. And this is going to be my femur. I don't have fibers. And then pressing together is compressing the joint when I stand or walk. Okay. Now on the sides of my fist here, I'm going to have my meniscus. Okay. So when I weight bear and press this together, I'm going to put a force through the joint, right? And if you look at the meniscus, right, I'll make this even a little bit bigger if I can here. So if you're looking at our meniscus here, and I apologize for folks that are just listening to this, I recommend going onto YouTube or at least looking at the video portion of this on Spotify. You'll notice that if you press into that joint, compress the joint, it's going to evenly distribute the force throughout the meniscus. And when you press from at least a locked angle, it's going to stabilize the joint by pushing the surgical surfaces together. Okay. So when you have a vertical tear, right, which is usually the type of tear that's going to be repaired, these hoop fibers are intact. So when you weight bear with your knee locked out, right, presses the joint together, it's going to stabilize the meniscal tear and not pull it apart. Okay. This actually changes based on the type of tear you have. So if you have a vertical tear, right? So if you look at this image kind of to the center left, that's a vertical tear. Same thing with the bucket handle tear. That's a vertical tear. When you repair it and you weight bear on it, it's going to stabilize the repair. Okay. If you have a transverse tear, kind of a radial tear, you have a tear that's going to start in the white zone and tear across, right? So kind of like a horizontal tear. When you weight bear on that, it's actually going to split apart the tear. Okay. So in a vertical tear, the hoop fibers are intact. When you weight bear, it's going to stabilize the repair. If you have a radial or transverse tear, the hoop fibers are disrupted. If you weight bear on that, it's going to separate the tear. Okay. So in those posterior medial repairs in the pig, as well as in the cadavers, they had a vertical tear, right? And when you weight bear on that, it's going to stabilize it. Might not be the same thing in these radial tears, okay? So that's one thing that's really important to just keep in mind here. So what happens when you look at human studies at accelerated protocols versus conservative rehab protocols, right? So we looked at pigs, right? We looked at cadavers. We have some basic science trying to figure out if weight bearing is going to disrupt the surgical site. What happens when you take a group of folks that have a meniscal repair and put them through a faster weight bearing period versus a group of people that go through a slower weight bearing period, right? What happens? Is one worse than the other? Do we get more failures in the group that has a faster rehab? So this study was looking at that. They're trying to figure the answer to this. A study was called Does High Knee Flexion Cause Separation of Meniscal Repairs? It's from Lin et al. In 2013. And they had two groups. They had what they called a free group and they had a restricted group. So in the free group, they had meniscal repairs and they were allowed to range the knee from 0 to 90 degrees immediately, right? So as soon as you start physical therapy, post-op, day one, whatever it is, you can range that knee 0 to 90, okay? No restriction. For the first 2 weeks after surgery, you're instructed to be touchdown weight bearing. So you're not putting very much weight through that leg whatsoever. And then your weight bearing is tolerated afterwards. So after you get through that 2-week period where you're really not putting any weight on that, now your weight bearing is tolerated. Go ahead and go for it, right? In the group 2, it was a restricted group. These guys were put in a hinged brace for a total of 6 weeks, so quite a bit longer, right? And we're restricting the range for quite a bit longer. They gradually increased the range of motion to 90 degrees over the course of time. They were instructed for touchdown weight bearing for a total of 6 weeks, right? So in the first group, 2 weeks, second group, 6 weeks. And then lastly, they were allowed to return sport at 6 months. So what was the outcome between the two groups? So essentially, there was no difference in healing rates at the 2-year mark, right? So if you're weight bearing at 2 weeks versus weight bearing at 6 weeks, doesn't seem to change things at 2 years when they take a second look with arthroscopy. So essentially, they did another surgery. They looked at the knee, right? So they could visualize the meniscus and what was going on. So at the second look arthroscopy at 2 years, there were 9 and 10 failures in the free and restricted rehab groups, respectively. So it was the same amount of failures, right, from group to group. And there were also no difference in functional outcome scores at 2 years, right? So at least from this experience, the authors concluded that free rehabilitation was safe without a higher failure rate, okay? So if you start early, seems to be okay versus starting a little bit later. This study was I thought a little hilarious. It's by Mariano et al. And this was in 1996, right? And I would call this a hyper aggressive protocol. So these guys were trying to figure out the same thing. They had 22 patients who underwent an outside in meniscal repair. They allowed the patients to weight bear immediately without range of motion restrictions. And they're trying to see if you can have a good outcome if you're much more quickly about getting folks to weight bearing and all the activities, right? And again, keep in mind, this was 1996. And on re-examination with MRI at an average of 28 months after surgery, so over 2 years, only 3 of 22 patients showed signs of re-tear with greater than 1 millimeter of gapping. Okay. So based on this experience, they actually advocated for more aggressive rehab regimens. What's interesting to me is that this study took place in 1996, and it seems like we've done the opposite of this. It seems like to me we've become more conservative with our rehab protocols over the course of time, at least with the surgeons that I tend to deal with, despite this earlier research showing we have decent outcomes if you weight bear right away and you also start ranging right away. I'm not going to sit here and tell you that you need to be more aggressive with your patients. I'm not saying that whatsoever. I'm just kind of pointing at some of the research and what the research is tending to show, right? So this next study I felt was a little bit more, I'll say, reasonable, right? So it's from Kokabi et al. In 2004. And they showed they had excellent results using rehab guidelines that was specific to the tear characteristics. And I feel like this is much more reasonable. So essentially, based on how big the tear is, the type of tear, they're either faster or slower with the rehab protocols, right? So you had 3 groups. They had one group was anterior, posterior, longitudinal tears less than 3 centimeters. Okay. So longitudinal tears, we talked about previously, which do a little bit better with weight bearing. And it was smaller, so less than 3 centimeters. These folks were allowed to do weight bearing as tolerated without a brace early on. And the range of motion was progressed to 125 degrees between 3 and 6 weeks. Okay. So probably restricted a little bit in the very beginning and then allowed to progress a little bit more quickly than some of the larger tears. For the same type of tears, greater than 3 centimeters, they advocated for weight bearing was allowed in a lock brace, and range of motion was limited to 0 to 125 degrees until 6 or 8 weeks. And after that point, they're allowed to, increase range of motion as they're able to. And then return to sport was allowed after 3 months. In the third group, they were looking at complex and radial tears, right? And these folks were required to wear a brace. They were weight bearing as tolerated, and they were ranging from 0 to 125 degrees for 6 to 8 weeks. And they returned to sport between 4 and 5 months. So it was kind of the slowest group here. Okay. So what I will say, and in this study, everyone here had an excellent result. Okay. I thought I had another slide next to this would help me explain this further, but I don't, right? So essentially, all of these folks did really well. All right. And it makes sense. But the thing is, they don't have a control group for each of these, individual folks saying that faster or slower would have been better. It's just that they did well with a slower approach, and they did better with a faster approach, right? I think this is a reasonable, but again, there's no control group there. So what I will say is that most of the papers that I've read are longitudinal tears. Okay. So these are the tears that tend to stabilize with weight bearing after repair. Okay. Hackler et al. In 2008 looked at immobilization and non-weight bearing for 6 to 8 weeks in radial tears. Choi et al. In 2010 used toe touch weight bearing that was recommended for 6 weeks, followed by a gradual increase of weight bearing over the following 4 weeks in radial tears. And they both showed generally good outcomes, right? So I think that the jury is out for weight bearing versus not. In these studies, they showed that the harder the repair, the more likely it was to be a failure. Makes sense. We know this. If we have a big tear, especially if it extends into the white or the red-white zone in the meniscus, it's just not going to do as well. It's more likely to have a failure, a worse outcome over the course of time, right? So keep in mind, like I said previously, in radial tears, weight bearing can separate the meniscus repair. So the thought process is you go a little bit more slowly with these folks, although the jury's still out. If we can actually weight bear with these folks and have a good outcome, we're not sure if we can do that early on or we have to delay. Okay. More research is needed. How often do you hear that? Right. So next, I want to talk a little bit about critical reasoning. Okay. So we just spoke about if someone has a radial tear, maybe we have to delay their weight bearing a little bit longer than someone has a longitudinal tear. That makes sense, right? So we know that if someone has a longitudinal repair tear, Then when we weight bear, it stabilizes the repair. And the radial, it doesn't do that. It kind of separates that tear apart. It makes sense. We probably need to wait a little bit longer. Okay. It's just that we don't have great research to show that that's actually the case right now. So it's important that you realize that I'm guessing based on critical reasoning. Okay. This is not completely evidence-based, but a few things that might want to dictate the speed of your progression, I've included below. So first one is age. If you have someone that's a little bit older, you may want to start thinking about delaying rehabilitation or delaying, not rehabilitation, but weight bearing, just because they may not heal as quickly, right? They're also more likely to have, let's say, a complex tear or a tear that's a little less favorable. But again, it's going to depend on the person. Is the tear acute or is it a chronic tear, right? So we do know that the meniscus can tear acutely. So like running, twisting, cutting, and then you feel a pop in the knee, you tear your meniscus. It's a fresh tear. Often that heals a little bit better. If you have a chronic tear, so it kind of broke down over the course of time, maybe that doesn't have the ability to heal quite as well. So if you have a chronic tear that's repaired, maybe you have to go a little bit more slowly, okay? The location of the tear is going to play a role. I'm going to show you an image in a minute. It's going to make a little bit more sense. But if you have a tear that's in the red zone versus the red-white zone, the red zone is going to have much more blood supply and it's more likely to heal, probably heal faster. So in folks that have a tear that extends into the red-white or the white-white, we probably want to go a little bit more slowly. If you have an anterior tear versus a posterior tear, then maybe that's going to dictate your exercise selection. This is a topic that I've explained in the past, but if you do deep knee flexion exercises, you're probably going to stress the posterior meniscus a little bit more than shallow knee flexion exercises, which are probably going to put more stress in the anterior portion of the tear. So you might want to change your exercise selection based on the type of tear, okay? The size of the tear may matter as well. So if you have a tear less than 3 centimeters, maybe go a little bit faster. If you have a tear that's going to be greater than 3 centimeters, then maybe you go a little bit more slowly. Okay. So what are kind of the takeaways and summaries? All right. Well, let me see right here. I thought I had a meniscal zone here. Yeah. So before we go into the takeaways, let me just show you the meniscal zones because I kind of promised you that and then I kind of bait and switched you. So this is a picture of a meniscus. I apologize if you're on Instagram, but I've got a picture of meniscus up right now. And basically you can see the different zones in the meniscus. I'll try to describe this as best as I can for the folks on Instagram right now. So you have the outer portion of the meniscus. So if a meniscus is shaped like a C, the portion of the meniscus that's closest to the outside of the joint is a red zone. And that just means it has a lot of blood supply. Go in a little bit from the outer border, you have the red-white zone, and that has so-so blood supply. If you keep on going in towards the inner portion of the meniscus, that's a white zone, and it has less blood supply. The idea being is that the more you're in the red zone, the better the meniscus will heal, the better the outcomes after surgical repair. So if you have a tear that's mostly in the red zone, then maybe you can go a little bit more quickly with your rehab. You have a tear that extends closer to that white zone, probably have to slow things down a little bit. Okay. So coming back, what are the takeaways and summaries? Okay. So like I said, there's a lot that we don't know. We don't have answers to all these questions. I'd love to see some more research about this. I think as a clinician, it's important to just take this with a grain of salt. I have all these ideas about how we should rehab based on the type of tear, age, etc., but we don't know yet if that's the case, if that's actually true. Okay. So when can we weight bear after meniscal repair? Early weight bearing seems to be okay for most tears. Okay. Seems to be okay based on the studies that it showed you. Okay. And it may be optimal. And we'll talk about this in a minute, right? Maybe this is going to depend on the type of tear, right? So if you have a radial tear, probably have to delay a little bit. If you have a longitudinal tear, maybe it's okay to progress a little faster. Again, where that tear is and how large that tear is maybe dictates your speed. Okay. I also think that you shouldn't go beyond the surgical recommendations. So if you have a surgeon that's a little bit more conservative, I would say if you're really concerned that they need to be pushing a little bit faster than the surgeon has kind of said in the protocol, just call them up and talk to them, right? And if it's a hard no, I would probably still listen to what the doctor has to say. Just keep in mind that you're assuming the liability medically if you decide to start progressing this patient faster than the surgeon says. And you can certainly reach out and talk to the surgeon, right? And if he says or she says, yeah, go ahead and progress them a little faster. If they're doing really well, then go for it. If not, I wouldn't push it, okay? I think this is also an important time to mention that you should find good surgeons. If you're a physical therapist, you should find good surgeons to protect your patients, right? You want to go to a surgeon that's really good at their craft and also understands rehab and trusts the physical therapists around them so they can make the best decisions for their patients. Okay. I think that's really important. So weight bearing, like I said, is going to probably depend on the tear type. If it has the person had a radial tear that was repaired or complex tear, we have to go a little more slowly. If that's a vertical longitudinal tear, we can probably go a little bit more quickly, probably. If it's an acute tear, maybe go a little bit faster. Chronic tear, slow things down a little bit. The location is probably going to play a role as well. This is another topic that I didn't explain very well, but largely your exercise selection is going to dictate if the stress is falling the lateral or the medial side of the joint, right? The size of the tear is going to also be a factor. Is this a big tear, small tear, right? And the last one is also concomitant pathology. This is a weird one, but if you tear your ACL at the same time with your meniscus, there's a greater likelihood that your meniscus will heal. The thought being is that if you tear your ACL, it's going to cause more of an inflammatory response, bring more blood flow to the area, maybe helps that meniscus heal a little bit better. I know that sounds weird, but if you have concomitant pathology, it might actually speed things up a little bit from a meniscal healing standpoint. Okay. So in terms of weight bearing, this is an important talk, I think, from a critical reasoning, and it is certainly going to affect your athletes. Okay. So the longer that you delay weight bearing after a patient has surgery, the longer it's going to take to regain their function, their strength, their hypertrophy, all of that stuff. Okay. And I think this ends up being a problem from a rehab perspective. If you have a surgeon that's trying to protect their patient and has a really long non-weight bearing period, are you protecting that surgical site? Probably. But what you're also doing is delaying their rehab. So largely, if you wait for a long period of time to start rehabilitation and you're non-weight bearing, you get a lot of atrophy, you get a lot of weakness, you delay the entire process of, let's say, return back to sport, return to function, okay? And that's a big problem because you make that rehab quite a bit more challenging. So I think when surgeons are really trying to protect their patients, they have to weigh the pros with the cons, right? So if I'm not weight bearing on this, I'm not potentially separating that surgical site, but I'm also getting that patient a lot weaker. We know that especially in ACL plus meniscus, these folks tend to have weakness for potentially years after they have repair. And that may actually impact long-term issues in terms of function, in terms of osteoarthritis. So if we're delaying folks to protect them, we might be causing more harm, right? We looked at that study from 1996, immediate weight bearing, immediate range of motion. Folks tend to have a pretty good outcome. So why are we waiting so long to get these folks active, get these folks a little bit more, movement in their life, right? Movement is good for the body. If you stop exercising for a long period of time, it's terrible for mental health, terrible for bone density, terrible for muscle mass. It's not good, right? So I think it's important that we weigh the pros with the cons. I don't know how many surgeons are actually watching my show, but I do hope that surgeons are taking that into consideration when they're telling physical therapists to delay. Okay. So lastly, if hoop tensile stress effect is preserved, we talked about this a little bit. So if you have a vertical tear, then maybe you can start an accelerated rehab program. You can start partial weight bearing probably a little bit sooner and then progress your range of motion a little bit faster. If those circumferential hoop fibers are disrupted, so think about those radial tears, then we're going to have to restrict our rehab a little bit more so, right? Wow. All righty. So that's not it for the learning, guys. I have another really good show for you. It's called When to Have Surgery for a Torn Meniscus. I'm going to leave a link in the show notes. If you're watching the recorded version of this, I can actually put a link up in the top right-hand corner of the screen so you can check out. I apologize if you're watching this live on Instagram. You can just head over to YouTube eventually for the recorded version. You'll see this. More great learning about the meniscus, right? Okay. Lastly, here are the references. I'll leave these in the show notes later. So if you want to read over any of these articles, if any of these are interesting to you. And then lastly, I just want to say thank you. Thank you so much for watching these. I love my career. I love educating, and I've been able to support myself financially by doing this. And it's amazing. I always have a lot of gratitude for folks like yourself by watching me. It means the world. So thank you so much for watching and joining me today. Next, we're going to go over some questions. So if you guys have any questions right now, leave it in the comments, drop it right there on Instagram or YouTube. If you are watching the recorded version of this, obviously leave a comment. I'll get back to you. And if it's a good enough question, I'll just do an entire episode about it. Okay. So I'm going to take a look at my phone right now and see if we got any questions. We'll answer them up and then we will wrap it up. All right. What do we have here? What's up? What's up? What's up? How are we doing? How are we doing? Okay. Oh, nice. Chris, thank you so much. Chris says I'm handsome. Love to hear that. Thank you, Chris. Not a question, but I'll take that. Okay. Scrolling down. Scrolling. Very good. Scroll. And that looks like it. Well, thank you very much, guys. I appreciate you joining me today. I will see you next week at 10:30. All right. Bye-bye.